Thanks very much, Jewel, and the Voting Matters crew. It's a great opportunity for us to be here amongst you, because I guess it does give us an opportunity just to present our understanding of what the truth is in our own clinical practice, and I think that's a critical part of the story that we're not hearing. So thank you for your time and attention. I guess this is me. Ordinarily, I'm a surgeon. I'm a gynecological surgeon. My special interest is in infertility and endometriosis surgery. And that's looked after me and my family very well, and my patients for many years. The challenge with all of this is that at some point, you get to the point in a career where you can't keep making allowances for dishonesty. And that's where I'm at. And so I'm stuck on the roundabout, but I don't know that that's a really big issue. Now that we're starting to see some cracks, thanks. Now that we're starting to see some cracks in the barrier or the barricade, I think it's really important that we do open our hearts to recognising that there are so many people who haven't taken the opportunity to go a little bit further and scratch beyond the surface to find out what the truth really is as it relates to them. And so I think, yes, there are people out there trying to silence us. The recent health practitioners amendment bill that was passed is a disaster, and we all recognise that. We're all on the pulse there. But unfortunately, it's only going to become more and more apparent. And so for me, in my own personal and professional career, the line in the sand was back in the 1st of November last year. And so interestingly, today is my first anniversary for having operated on a patient. My last patient I operated on was on the 25th of October last year. So that's a bit of there's a pang to that. And this is where I think this one is helpful and worthy of being aware of. And humility, particularly in this context, is about being honest and being accepting of the truth when it presents itself. And that's, I think, our challenge, and each one of your challenges is to try and get that message out in a kind, careful, cautious and loving way, so that people are actually open to listening to what you've got to say. And that will win hearts and friends and ultimately take this whole thing down. Lots of writing here, but at the end of the day, what we were trying to put out was, in terms of pregnancy, the impact of COVID on pregnancy is really not as bad as they made out. It took 4 cases of Zika before it became apparent that Zika has a significant impact on pregnancy. Whereas we were well into the pandemic before we sort of started to say, well, there seems to be an increased risk of preterm birth, that PTB thing up there, and there seems to be an increased risk of stillbirth, but it's very hard to put it all into context. And certainly there is a case series recently of about 60 infants that sadly died of stillbirth in the setting of a mother having had COVID, and found that there is a particular thing that's very rare called placentitis, which is an inflammation of the placenta, which in essence shuts down the placenta from functioning, leading to stillbirth. But it's not every baby. It's really quite uncommon. So normal rates of stillbirth is about 1 in 800 term pregnancies, that is a pregnancy beyond 37 weeks. In the setting of, so if you had 800 people with COVID, it's about 1.6. So it is increased, but it's only very, very small. And that's the barrow that they push to say, well, we need to vaccinate all of them. So we'll just scratch through a little bit of that as well. The other thing, and I only had this today brought back home, which is the last line, but the Director General of Queensland Health, of the Department of Health, brought out on the 29th of September a correction or an update memo to the directive. So the directive came out on the 11th of September to say, everyone, Queensland Health needs to be vaccinated. On the 29th, and this was a point where I thought, wow, there's a little bit of sense here, that there will be an allowance for pregnancy exemption for anyone who was pregnant at the time of the directive, 11th of September, until they return from maternity leave. So I thought that was reasonable. The challenge is, of course, a poor woman who finds out that she was pregnant on the 12th of September is not eligible for the exemption. And in fact, I had a lady today who's on maternity leave, and she has been threatened quite seriously in writing for actually taking her maternity leave back off her because she hasn't provided any proof of vaccination. And yet the directive was very clear. The memo came out saying she's exempt until she comes back from maternity leave. So they're trying any foul trick to scare people and bully people into this. I think when we talk about vaccinations, we've just really got to be careful of understanding, and I think I've mentioned this before, is when a new product comes to market, it'll always be its best. A new car, it'll be fantastic until you realise that the bearings are wrong or something's not quite right. And it's exactly the same with any medical product. You're going to have the best you can present, the safest, the most effective, etc., etc. It'll come out with a glowing school report until it starts to hit the ground running and we start to realize that there's chinks in the armor. And so we need to recognize that there's known and unknown harms and benefits. We just need to be honest about that. And the reality is that hasn't been honest at all. And the minute that it starts to lose the gloss, they just go back layer upon layer of silicon just to allow the story not to stick, just to keep buffing it up and make it look good. The ACE2 receptors, you're probably very aware of the fact that the spike protein, which is the problem in this whole COVID saga, is that the spike protein attaches to the ACE2 receptor, and that's all the way through women's reproductive tracts. So yes, it's in cardiovascular systems, it's in renal systems, and it affects multi-systems, but particularly for women in the reproductive tract. Additionally, there's some more recent evidence that is actually a preprint, so you're probably very familiar with preprint now, probably never heard of it 12, 13 months ago, but there is a preprint showing that it also affects estrogen, which is one of the core hormones of women. It affects its estrogen production at a cellular level, at the nucleus of the cell. So there's two reasons why women particularly will be harmed, you would expect, by COVID in the first instance, but also the purified pathology part of COVID in terms of a vaccine. As a gynecologist who has a particular interest in infertility, my job, I guess, is to go back and say, well, what impact do these vaccines have on my patients? Because I need to be able to be honest and tell them what the particular, this is about informed consent, the knowns, the unknowns, what are the particular things we need to be aware of if you were to approach your GP and get vaccinated? Preconception, so before pregnancy, during pregnancy, early pregnancy, or in breastfeeding. And it became very apparent very quickly that there just wasn't information that I could make a call on. Now that's very new, that's quite unique. Normally you should be able to go through, scratch the surface, look around at some of these papers that are referenced in a lot of the guideline documents, and not just read the abstract, the front sort of the conclusion, but actually read the nuts and bolts, because often the conclusion that's presented in the abstract comes out of thin air. And it's like, how on earth did they get that conclusion out of what they've just written? And that happens more and more and more frequently of late. But these are just some freedom of information application numbers that relate to reproduction. And in essence, some of the things that we worry about are the lipid nanoparticle, which is the little wrapping around the mRNA component of the vaccine, seems to have a preponderance for the ovaries. So 10 times higher concentration in the ovaries than most other areas of the body, aside from the liver and the spleen. But the ovaries don't have the ability to regenerate or reconstitute themselves, unlike liver. So that's a problem. The controls, when they looked at the mice models, Wistar rats rather than mice, Wistar rat models, and they found that in the control group, the miscarriage rate was a whole lot less, in fact half, so 4.1% versus 9.8% compared to the actual intervention arm, that is the actual Pfizer. Pfizer had 3 doses in this study, but they found that it was 9.8%. So automatically that should sort of at least raise some concerns. It doesn't. They just passed it aside and said, that's okay, it fits in historical miscarriage rates for these sort of studies. The Freedom of Information 2565 is still undergoing an application. So it's been put in, rejected, come back, adjusted, put in again, rejected, come back. It's gone to the Information Commissioner, it's gone to the Ombudsman, it's a formal complaint. As of, interestingly, it's its first anniversary as well, 25th of October, and it's still an unresolved issue. You'd think they're after the crown jewels. They're not. All they're after is the histology, that is looking at them under a microscope, looking at the ovaries of these rats that were in the studies. It's not hard, is it? And so if it's not forthcoming, you have to say they either don't have any information, or we forgot to do that, or they have information they don't want us to know. That's the only assumption. I think that's a fair and reasonable assumption. So hence I'm stuck on the roundabout. The final one was 23 pages of mostly redacted data, and that's what's on the right-hand side. But one thing they felt that was reasonable for us to note was uterine swelling and collections of clear fluid. What was that about? I mean, that's a concern. That's not normal. If I did an ultrasound on a woman and found sort of a fluid-filled uterine cavity, it behoves me to take that and investigate a little bit further. So they felt that that was appropriate for us to see. So a college, RANZCOG, the College of Australia and New Zealand for obstetrician gynecologists, came out with a whole pile of different points, but they really, and this is 18th of August 21, there was a bit of an unknown. What do we do with vaccines? Do we vaccinate women or not? And they came out with this guideline document, and the top 3 points were fairly clear: that pregnant women are a priority group, Pregnant women do not need to delay vaccination or avoid becoming pregnant after vaccination, and that's a point I have a real issue with, and I'll present the data of my own practice. Real-world evidence has shown that it seems to be safe for pregnant women. So they didn't study anything. It so happens that we've looked at these women and it sort of comes out okay, so let's go for it. And then the final thing is, and this really should, this implicates them. The college emphasises the importance of inclusion of pregnant breastfeeding women in clinical trials to develop evidence-based advice. So they recognise that this and the other 12 points above these that I didn't raise for this slide were not evidence-based. It was just consensus opinion or guideline type stuff. So that's pretty scary. And certainly since then, there are some pregnancy and breastfeeding trials that have been coming out. My particular area of interest is hormonal deficiencies or hormonal problems in early pregnancy or infertility with regards to women not ovulating well. So ovulation is the process of releasing an egg that subsequently becomes fertilized and becomes a pregnancy. So that we can put all this into context, the spontaneous miscarriage rates at different age groups is what you see here. And roughly in the cohort that I would work with regularly, it's sort of 15 to 25%. The work on the right-hand side is just some recent or some previous research, 2018, looking at how important hormones are for women who experience things like infertility, miscarriages, or ectopic pregnancies, a pregnancy that doesn't make its way down the tube into the uterine cavity. And so there's something critical with regards to the important role that hormones play in this space, and I'll pull that out a little bit further. This was a trial, so a randomized controlled trial, so you get a group of women, so we had 278 women present to us with a threatened miscarriage, so that they were having some spotting, bleeding, plus or minus pain, and they were given either a placebo or progesterone, the hormone progesterone, to try and see whether we can decrease the likelihood of them progressing onto a miscarriage. Now that scenario, a woman who's presenting with a threatened miscarriage normally will proceed to a miscarriage about 25% of the time. And so we did the numbers on the trial and thought we need around about 380 to see if it's going to make a difference and drop it to about 12-13%. Interestingly, what we found, we pulled the trial out early, makes absolutely no difference. The live birth rate was about the same, 84% in both arms. So it goes to show there's a whole pile of other things at play. It's a very complex area, early pregnancy. And so don't pretend to have any of the answers or some of the answers, but it's important to show that this was a high-risk pregnancy trial where we normally know 25% would proceed to miscarriage, and we had 16%. So 16%, we started to throw this sort of figure around that 16% is what you would expect a miscarriage rate in a high-risk population. So let's look at this population. Now, more recently in mainstream news, we've found that the 85% of the population being vaccinated before COVID hit the shores is not right. We know that, which is no surprise. Many of us were aware of that sort of data in the background, but we have to be honest with what we were being told. 85% of the population, at least we were told, had been vaccinated before COVID hit the shores. And what I've looked at is the college, I mentioned the College of O&G brought out a guideline on the 18th of August, 2021. What I did is I looked at 11 months prior and 11 months since they brought that guideline document in. I only had 2 women in the cohort prior to that August guideline who had been vaccinated, and one sadly miscarried at 20 weeks and 3 days and one at 7 and a bit weeks. So the only experience I had as a doctor was that the 2 women who had been vaccinated had both miscarried. They did not have a baby in arms. And so that alerted me to say, well, I need to watch this space very carefully. Now, the other thing is, in terms of the data that we have, I'd like to say it's very tight, somewhat proudly, because a lot of the information that's coming out on the pregnancy safety is population-based stuff. If women remembered, and this is a particularly emotionally draining time for families, a miscarriage, you're not going to remember to go, oh, I better go to the VSafe register and note that I've had a miscarriage. It just doesn't happen. We see it all the time. Women being asked to come for their first appointment to the hospital, and then the woman says, oh, I'm sorry, I had a miscarriage 3 weeks ago or 5 weeks ago or whatever. So that's just the nature of the story. And this, I think, is the take-home slide, is that what I had prior to the guidelines, so the pre-vax guidelines, I had 51 pregnancies, 10 of those 51 miscarried, and that was my patient cohort. Since the guideline came in August 21, I had 62 pregnancies in the subsequent 11 months. I was busier from a pregnancy point of view because I was no longer operating. 30 of the 62 miscarried. Okay, so there's something there. Now, I don't pretend to say what it is. I'm just saying what I'm seeing, and that's my practice. I've actually, in the last few weeks, decided not to practice anymore. I cannot practice in that environment. So I think and a lot of the naysayers will say, look, that's crazy. This is just because you've got an older cohort of women. You know, during COVID, the only people who are going to be having pregnancy or trying to get pregnant are those who are desperate to have a baby, knowing that their time's running out come 40, 41, 42. So of course you're going to have a higher miscarriage rate. Well, the reality is you've got 35 years of average age in the far right-hand bar and 33.8 years in the left-hand bar. Not much of a difference. It might be 1 or 2% miscarriage rate in that, but certainly not double or double and a half. And that's still going. And so I've got the data, and I haven't yet put it together, but I've got the 12 months, because particularly with birth, you've got to be careful. You've got to capture the whole 12 months. There's a lot of seasonal variation. So I've now got September to September to September. So I've got 24 months, 2 12-month periods, irons out all the naysayers, and then we should be able to actually publish, hopefully. It'll probably only ever stay as a preprint. So some preliminary findings as well. So the kind of stuff we hear in the mainstream and in our published papers, and I really want to bring anyone presents you a published paper, ask them, what's the conflict? Almost universally, there's a significant conflict of interest that those authors have in getting that paper published. But there are a few things in my little cohort that actually show that some of what we're seeing in the mainstream literature is probably correct. Is of the 20 of 21 women vaccinated in pregnancy proceeded to live birth. So that's only a sort of a 5% miscarriage rate once they're pregnant and get vaccinated in pregnancy. And that's what we're hearing. That's the story they keep pushing out. They don't talk about what about the women vaccinated just prior to pregnancy or in early pregnancy. The 3 of the 4 women who are vaccinated in early pregnancy, so that is from ovulation through to 6 weeks gestation, 3 of the 4 miscarried. Okay, and that's the kind of stuff that is coming out in some of the Pfizer documents that are being released. So if you capture, if it's too early, if it's in that preconception, and that's what I'm finding, when I drill down a little bit further, if they're being vaccinated up to the 6 weeks prior to conception or in the early part of pregnancy, that's when the miscarriages happen. So it's causing a lot of inflammation, and I'll quickly talk about some plausible mechanisms. There doesn't appear to be, and I've only had 8 women in this cohort that had a booster in this series, but they all seem to do fine. Although I note that the one mRNA that TGA has accepted as being a death was a woman who had a booster, so it's not without risk. And the elevated miscarriage rate of late seems to be about the same in the vaccinated and unvaccinated cohort. And so that's something that needs a bit more exploring. So some plausible mechanisms, and the interesting thing is, when I first sort of gave this presentation back in whenever it was, it's been a long year, hasn't it? Probably July. There really wasn't much information out there. There's stuff starting to come through in the mainstream literature. So I've just quickly put the author's name in that, but most of these papers have really just come out August, September. But we're finding menstrual cycle changes, generally by about 1 day. Up to 10% of women are having at least 8 days menstrual change in the cycle of vaccination. It seems to iron itself out within 1 or 2 cycles. So it's causing something. Now, interestingly, in that paper, they found that women who'd been vaccinated twice in the same cycle had generally a longer delayed ovulation, okay, by 3.7 days. So I've written it as 4 days. But that tells me that if you capture it in the second half of your cycle, it's not really going to change anything, because the process is already, you've ovulated, that process is a finite amount of time, it's not going to change. But if you get in before ovulation, you're going to jam things up a little bit. And that makes sense. So, you know, my simple take-home message would be, if you're planning, or your friends or family or loved ones are planning a pregnancy, try and not ideally don't get vaccinated, but if you do get vaccinated, wait at least 2 cycles. Impaired ovulation, I think at the end of the day, I look at providing hormone support for these women to support their pregnancies, and overall I found lower levels of hormones in these early pregnancies, and many more have needed more hormones to support these early pregnancies, even when I've got a 48% miscarriage rate. We know the lipid nanoparticle concentrates in the ovaries. We don't know what sort of effect it has. We cannot access the histology, the microscope slides of those rats. We don't know whether it diminishes ovulation. We don't know if it diminishes ovarian reserve. It would be nice, and at the moment I'm not aware of anyone. If you're familiar with AMH as a marker, AMH is a marker of fertility potential or reserve. And no one's really looked at what are the average AMH rates 2 or 3 years ago versus what they are now. And it should be a very nice, simple study that would bring it out very clear. Inflammation, there is a paper that came out showing that for women who suffer from endometriosis, there seems to be an exacerbation of all of their symptoms to what I've got as a relative risk. That is a 4.3 times increase in pain, a 5.5 times increase in all symptoms of endometriosis, whether they do or don't have the disease there. And endometriosis is an inflammatory condition. So this is just jumping into bed with another inflammatory condition. And so we know that that's what's happening. There seems to be, there's a couple of studies, that's one of them, but that there's a genetic predisposition to having some changes. So sudden death, unexplained death. So we're starting to get a little bit smarter about this. And cytokines are sort of inflammatory proteins. And they're particularly, you can imagine an embryo trying to land in the lining of the womb. There's a very, very tight balance between pro and anti-inflammatory cytokines. And so that's the important thing we need to look at. And if you're getting upregulating of all of this inflammatory system, well, of course you're not going to even implant, let alone carry that early pregnancy. And then more recently, Hannah's paper that showed the breast milk expression of mRNA in 5 of 11 women. Now, there was a lot of samples. I think it was 130-something samples, and it was only present in 5. But mRNA was present in the breast milk of these women. So from a fertility point of view, that's a quick capture. And now we're starting to get some papers coming out. And my experience is nowhere near that yet. It's not even at preprint stage. It will be in about a month. But so it's a scary space. And then I put that up there. I don't have any stickers to hand out tonight. Jewel kindly let us come along to advertise tonight's event last time, so I handed all my stickers out then. Okay. So feel free to take a photo of that. Thanks.